So let's get back to where we left off. So we stopped off at the occupational lung diseases. So now we're going to go into something called ARDS and IRDS. So where before did we look at ARDS? In what chapter of what disease?
I remember.
You remember?
I forget that.
Not pulmonary, cardiac?
Cardiac, yes, but what type of condition
Yeah.
in cardiac?
You mean the hypo?
Where did we see ARDS? ARDS was a condition that followed something else. That could follow something else.
Cardiac disease, or cardiac disease.
What type of, well, not so much a cardiac disease, but what type of cardiac situation?
High blood pressure.
Not hypertension.
Myocardial.
Is it just everything?
Shock.
Oh.
Somebody said shock.
I said that.
You said that? I was going to say, I'm sorry. Okay, shock. Remember, this was a complication of shock. So sometimes patients can go into shock, and especially when we talk about septic shock, and then some other types of shock, it can lead this patient into having an ARDS. Okay, so they can go into an acute respiratory distress syndrome. But keep in mind, just to give you a heads up, not only just ARDS, but sometimes patients that do have severe pneumonia can also go into respiratory distress as well. Okay, so it depends on the situation. Now, so they give you the etiology here as far as the number of cases that occur. This is quite common, unfortunately. Okay. And sometimes this can lead to being very fatal, okay, if it gets to that point. Now, the causes here: severe trauma, sepsis, as we talked about with septic shock as well, okay, shock, sometimes aspiration of gastric acid, and fat emboli. Okay, so there are some causes. Now, this box here, box 23-1. This goes over a lot of different causes. Now, I will tell you to please look at this. Okay, please look at this. If you need to memorize the whole thing, memorize it. But once you read through this, you'll get an understanding as to all the causes. Okay, so shock, any type of shock, let's just put it that way. Okay, can lead a person into ARDS. Trauma, okay, any type of obstruction, embolism, whatever, wherever it may be. Head injury, aspiration, even here they have drowning, okay? People that drown and they aspirate all the salt water, okay? That can also cause an ARDS. Drug overdose, okay? And they give you all the drugs there. Inhaled toxins, okay, which we kind of talked about a little bit with some of the respiratory, occupational respiratory situations. Hematologic disorders, metabolic disorders, burns, cancer. So pretty much, I don't want to say everything, but almost everything can lead to a person having an ARDS, okay? So if you see that as a test question, and don't get confused that, okay, if a patient has, you know, a couple of things going on, that it can't lead them into an ARDS. Yes, it could, okay? So it's not just always just shock and just a respiratory situation. Okay. So that's that. So please go through that box at home. Now, the pathogenesis here. They do have widespread pulmonary inflammation. Okay. Now, what happens with this pulmonary inflammation is that when it's time for the gas exchange to occur, and they have all this inflammatory process going on, when you have the capillary alveolar membrane level, when it's all that inflammation that's going on at the capillaries obviously will inflame, all the inflammation that's going on at the alveoli will inflame the capillaries. Capillaries at that time will get what is called leaky, and they will start to leak fluid, okay, because keep in mind the inflammatory process do secrete a certain amount of SQD, okay. So this is what can happen with these individuals. The other thing that this is associated with as far as the pathogenesis is that these patients have what is called atelectasis. Atelectasis is what we call a collapse alveoli. Okay, so that's a term for collapsed alveoli. When the alveoli collapses, this will result obviously in a decrease in gas exchange. Okay, so just keep that in mind. Once the alveoli collapse, this will cause a problem with gas exchange, obviously. Now, what causes this collapsing of the alveoli, okay, it's not so much just the inflammation in this situation, but the inflammation will get to the point where it will attack the alveoli and decrease the surfactant. You know what surfactant is for, right? In the alveoli, keep in mind that the surfactant is there for the surface tension, okay? So we're able to keep the alveoli nice and tight, so it'll be able to function as it should. So what will happen is when all this inflammatory process is going on, it'll kind of wipe out that surfactant, and now the alveoli will collapse, okay? So again, this can happen as a result of numerous diseases, secondary to other diseases. So, decreasing the surface tension, preventing it from collapsing. Fibrosis, keep in mind that as we go through the more inflammatory process, we know that fibrosis is the last stage, and when that happens, we know that we're in trouble. Okay. Now, another thing, a couple of other things that go along with this has quite a bit of pathogenesis, so I'm just going to point out the ones that are quite important. Okay. So, definitely injury to the alveoli, injury to pulmonary circulation. Okay, so at that capillary level, it's not happening. Okay, so blood that needs to be going over and crossed over is not going to cross over. So it will disrupt the oxygen transport and how it's utilized. Severe hypoxemia will happen with these individuals. Okay. Decrease in lung compliance. And with decrease in lung compliance, what happens here is that because they don't have these proper surfactant, what will happen is that the alveoli, we know, are going to, expand and contract. So they don't have that expansion and contraction as they should. Okay. So it's not moving, okay, or as they say, an increase of recoil pressure. That recoil pressure is not there, okay. And that's that. The fluid fills the alveoli, which we know from inflammatory process. Now, decrease in functional residual capacity. Functional residual capacity. Do you guys know what that is? Do you remember from physiology in the lung? So keep in mind, we know that we do have something called residual volume. What is residual volume? Very good. So it's the amount of air that's left in your lungs after you exhale. So that amount of air that's left in your lungs after you exhale is staying there for what reason? It keeps the lungs from deflating, and also there's another reason why we have that air still there. Keeps the lungs open, but it's for diffusion. Keep in mind that when you exhale, diffusion doesn't stop. So you don't stop diffusion when you exhale. So keep in mind that you do need that oxygenated air in the lungs to still have that proper diffusion going on at the alveoli capillary level. So what happens with these individuals, what we call is functional residual volume. Functional residual volume is when we have the right amount of O2 that's in the lungs, the right amount, okay, or functional. What happens here, they decrease their functional residual capacity, okay? So when they exhale, the diffusion is not occurring as it should. Okay, so this is the situation here. So when that happens, this can definitely lead these individuals to have, yes, as you said, collapsing of the alveoli. So if they try to breathe out or exhale, and the body normally is still continuing with diffusion, but they don't have enough air in their lungs to have that diffusion, the alveoli are definitely collapsing. Okay, so that's that. Now, clinical manifestations early on, they can have some respiratory distress. Oh, I didn't even see. That was weird. I just thought somebody was coming. Okay. Dyspnea, definitely low oxygen, shallow rapid breathing. Okay, so all of these things you can memorize. Late finding We already know cyanosis is always a late finding, hint, hint, okay? Tachycardia, tachypnea, hypotension, blood pressure will drop. And they will have crackles in the lung, okay, because they are excreting fluid, and that fluid can get inside the lung, okay? Because the capillaries, remember, are leaky, yes.
The crackles, is that a sound or is that the one?
That's the sound in the lung. So what happens when you listen to a patient's lung feel and you tell them to breathe in and out, all you should hear is just them breathing in and out, just the normal air. But when you listen on the stethoscope, and you'll hear like a crackling appearance when they breathe in and out. Because when they breathe in and out, now the fluid is moving. And so you'll hear it as a crackling sound. So that crackling in the lungs, again, most of the time comes from the fluid that has been excreted from the inflammatory process. Or sometimes when patients have pulmonary hypertension, they'll have a buildup of fluid in the lungs. Okay, so because the capillaries get leaky, okay, because of the pressure. Okay, so then they'll build up with that fluid in the lungs. So that's what the crackles. The crackles is the fluid moving around, and you'll hear it. So they will use accessory muscles to try to breathe, okay, and external retractions because of the whole breathing mechanism and late finding cyanosis. Now the hallmark here, they say, is hypoxemia refractory to increased levels of supplemental oxygen. Okay, so what does that mean? This means that you'll have this patient, and even though you're giving them oxygen, their oxygen levels can still be low. They still can continue to drop. But there's a method to this. You have to make sure their oxygen levels actually go above 60 millimeters of mercury. So the goal to take care of this is to make sure that the oxygen levels go above 60 millimeters of mercury. Okay? So you can keep giving them oxygen, but if it's not reaching to 60 millimeters, it's actually going to keep dropping. Okay? So and that could be an issue, but it's not so much of an issue because you know to give a certain amount. Now, hypoxia, acidosis, okay, which we know can result from a lot of oxygen, and hypercapnia. PFTs are abnormal. Okay, that's all I need you to know is that they're abnormal. And with ARDS, these individuals do have on the chest x-ray what they call a diffuse whiteout appearance. Okay, so what does that mean? That means that they have so much inflammation that can occur, and because of the collapsing of the alveoli, you will just see, you know how before we saw just little white spots, little infiltrates? This will look like someone took an eraser and just kind of erased the whole lung field, okay? And I have a picture, let me show you that. Okay, so if you look at this picture here, everything is white. As you know by now, the lung fields are dark, okay? They should never have a white appearance to it. So if you look at this x-ray here, this area is sort of white out appearance all over here. Definitely this whole lung field is white. So what you're looking at here is just the amount of destruction, okay, that's occurring here. Okay, so that's what that looks like. Okay, so with the open lung biopsy, this is another type of testing that can be done. Okay, atelectasis can be present. Okay, so the collapsing of the alveoli, hyaline membranes, any type of fibrosing cellular debris. So all of that stuff can be pulled from that biopsy, or actually shown in the biopsy. So when we look at this histology slide of the alveoli, what are two major things here that you see are the issue that goes along with the pathogenesis? Very good. It's just so thick. Okay, so if you look at that alveolar wall is extremely thick. Okay, it should not be that thick. And then what else is the issue? They're not as round. They look kind of abnormally shaped. But keep in mind, even in between, this is the lung tissue, we have all of this stuff in here, okay, that should not be. Okay, so this is too much inflammatory cells. Keep in mind the lung, any type of lung tissue airway should be clear. Okay, it shouldn't have all of this in there, and that's just congested. Okay, so treatment. Main thing here, again, first thing, if they need oxygen, that's definitely number one. Okay, to give them oxygen. So any type of support to enhance tissue oxygenation. Identify the underlying cause. Keep in mind, ARDS is usually secondary to a pre-existing condition. Please make sure you understand that. Usually patients don't just have a spontaneous ARDS, okay? They could, but that's usually not normal, okay, or common, I should say. So it's usually from some sort of shock or some sort of injury, drowning, heroin overdose, whatever it may be, it can lead into a person having this. Make sure they have the right amount of fluid electrolyte balance, okay, and block any type of inflammatory cells. Now they go over in the next two slides, this slide, with treatment. All I want you to understand with this is that they will give them oxygen. I don't know much about management with different ventilators, okay, just to let you know. But sometimes they do have to give them oxygen in different formats. So they will give like a pressurized ventilator or what have you. But I'm not going to test you on, okay, but what type of ventilator, okay? But just make sure you understand that they have to have adequate amount of oxygen, and it has to at least be more than 60 millimeters of mercury. That is important to know. And the reason that it has to be over 60 millimeters of mercury, just to add to that, is to make sure they have proper diffusion, okay, that can take place at the capillary level. Okay, now the next one, IRDS. Okay, so again, that's just talking about the different type of ventilation. So there's a picture we already looked at. Now, IRDS, pretty much like ARDS, but this is in infants. Okay, so this is infant respiratory distress syndrome. Now, they give you here the incidence. You can just go over this. I'm just going to highlight a few things, and I just want you to understand. Most of the times, this is something that is found in premature babies, and not only in preemies, but also moms that have not had proper prenatal care. So that's pretty much the topic for this. And we're going to go into, they're going to show you a lot of different things and different types. But it's usually coming from premature babies and the mom not having proper prenatal care. Okay. So, high risk, okay, prior birth to 25 weeks gestation. So definitely we're talking about premature. Advanced gestational age, so what do we have? The over 35 crew, over 40, okay. Poorly controlled diabetes in the mom, deliveries after antepartum hemorrhage, so hemorrhaging after the birth, before the birth, antepartum, before the birth. Other high risk C-sections that don't have any preceding labor, perinatal dysphagia that can happen, okay. They say second twin. I don't know how that happens with the second twin. So there's a lot of different things. The RH, as you know, previous infant with RDS, RH factor incompatibility. You guys probably talked about that maybe in physiology or anatomy. You know what that is. Keep in mind that, again, that comes from not having prenatal care, because you all know that if mom has proper prenatal care, this situation never is an issue. Okay, because they'll give them the Rogaine and that takes care of that. So, now, what happens here with these infants, they are born with, or they're lacking what is called surfactant. Okay, so we already know what surfactant is for. So when they lack the surfactant, here we go, we have an instant atelectasis, alveoli collapsing. Okay, so that's that. Now, Some of this is saying the same thing that we talked about with ARDS. Okay, so progressive active-like stasis, we know leading to hypoxia, acidosis, saying the same thing. Okay. Immaturity in capillary blood supply. So, if they have a collapse in alveoli, what happens here is that the alveoli is collapsing. We're talking about an infant, okay? So not a developed person. So what will happen here is that the capillaries will actually not be able to function as they should, because they're not going to be able to develop as they should if the alveoli is collapsed, okay? So then now we're talking about even having more of an issue of diffusion, okay? So by adding, as they say, more hypoxemia and metabolic acidosis, because they're not getting the proper diffusion as they should, and they're actually now increasing their carbon dioxide levels. Okay, so progressive damage to the basement membrane and respiratory epithelial cells. Keep in mind that because the capillaries are being affected, that they can have leakage of fluid into the alveoli, now causing extra fluid, now causing obviously more congestion in this situation. Now, clinical manifestations. Early signs, shallow respirations, decreased breath sounds, retractions, flaring of the nares. Now, sometimes what happens, oh no, it's in the next slide. So this is early on, where they're just, obviously these babies will have issues breathing, okay? So just like when a person has like a bronchitis or emphysema, they'll have that sort of breathing where they're trying to breathe from here and they can't breathe in the belly, okay? Now, late finding, they can have frothy sputum, okay? And that sputum comes from the fact that they do have a lot of fluid that's there. And cyanosis, late finding. Grunting sound when they breathe, and what is called paradoxal respirations. Have you ever seen, and I've seen this on TV, not in real life, but have you ever seen babies in the incubator and they have respiratory conditions and they're breathing and it looks like the chest is just moving back and forth and it's jumping out? Okay. Now, what's happening here is that they have this sort of seesaw movement because they're trying to get as much expiration and inspiration as they can, okay? So this is what they call that sort of seesaw movement of the chest wall. Has anybody ever seen that in real life? You've seen that in real life? Okay, yeah, when it moves up and down. So they do have that, and this is how you know that they are pretty much compromised, okay, as far as their respiratory system. Okay, so ABGs, hypoxemia, metabolic acidosis, hypercapnia. Okay, so we know that goes across the board with these individuals. Chest x-ray, they will also have a whiteout appearance just like ARDS, okay, if you were to do that. Now, another diagnosis that is, I would say, the hallmark of this one that sticks out. You know when the moms are pregnant and they do go through what is called the amniocentesis, okay? We know that amniocentesis, they take out the amniotic fluid, look for all the different things, genetic diseases and so forth. Now, what happens also with the amniotic fluid, they can look for something called lecithin-sphingomyelin ratio and desaturated phosphatidylcholine concentration. I know that's like, what is that? Okay, say that 5 times. Now, all that means is that this fluid, if they look at the ratio of this fluid, this determines how much surfactant this baby's going to produce. Okay, so they can do this just through amniocentesis. Okay, so with the amniocentesis, they can tell, okay, well, what is the issue here, if it is going to be an issue. Okay, so that's basically that. Now, treatment, prevention is primary goal, so very important to have amniocentesis. I remember I used to work in the OBGYN office a long time ago, and I know that amniocentesis at a certain age, it wasn't mandatory, but then once you're high risk, it's mandatory. I don't know if they still do it that way. 45? 35, but before 35, it's not mandatory. Okay, so they still do it that way. But it is good to have it done, okay, because again, it tells a lot of things, and especially this is one of the conditions. So you can prevent it if you know it's coming. So, adequate amount of oxygen if the baby is born that way. Keep in mind it has to be somewhere, as they say, oxygen levels 50 to 90 millimeters of mercury. So obviously making sure it's above 50 if possible. And whatever type of ventilation they need to do that. Now another treatment that can be done, and I believe this is when they find out from amniocentesis, they can give, and I don't know if this is through an injection, but they can give exogenous surfactant. So it can be surfactant from maybe synthetic or bovine or what have you. So they can give the mom or baby the surfactant, okay, to take care of that situation. And they say it decreases the mortality rate quite a bit. And then any other kind of ventilation that is needed. Antibiotics if they do have an infection, because sometimes in this stage they can be a little more immune compromised and more susceptible to infections. And any type of supportive therapy, so fluid electrolytes, intravenous. Now, it was something I was going to ask y'all. Okay. Last thing is pneumothorax. Pneumothorax we kind of talked about already, right? Did we talk about pneumothorax? With what disease did we talk about pneumothorax? Did we talk about pneumothorax?
With the chronic asthma.
I think we did. Not asthma. Emphysema, very good. Emphysema. Okay. So pneumothorax is air in the pleural space. Okay, so keep in mind, as I showed you before, you have the lung. We know over the lung cavity, or in the lung cavity, we have the pleura. Pleura covers the lung field. Now, in between the lung and that pleural cavity is just a space, okay? If we need that pleura over to kind of reduce the friction with the air, okay, the lung just expands and contracts. Now, we just want it to be just plain space. We don't want too much air, no fluid in there, nothing, okay? So, just keep that in mind. Primary pneumothorax, they say that this can be spontaneous. Sometimes individuals can have a spontaneous pneumothorax. And they do say that this can occur in individuals that are tall, thin, men between 20 to 40. Smoking, they say, increases this risk, okay? So that's that. Now, secondary pneumothorax, this is the one that we talked about last week, where this is usually associated with a person that has an emphysema or some other type of respiratory condition. So just make sure you know that one. Secondary is from a pre-existing condition. Now, we do have some other types of pneumothorax which are quite interesting. Catamenial pneumothorax, this is associated with menstruation. We have primary right, and then some that are associated with endometriosis, okay? Now, how this was explained to me, and it's still quite strange every time I think about it. How this was explained to me was that sometimes when females have endometriosis, and hopefully we'll go into that next week when we do reproductive disorders, they do form something called chocolate cysts. Have you guys ever heard of that? Huh? You've seen one, okay. Now the way it was explained to me is that these chocolate cysts that do form from the lining can leave and get into the cavity. And it gets into the cavity and somehow it gets through up into the pleural cavity. Sounds crazy, but that's how it was explained to me. Okay, so the point here is that they can have this sort of increase, or this chocolate cyst can actually move and get into that area. Okay, so that's that. Tension pneumothorax, this comes from injury, trauma. So a person that has a stab wound, gunshot wound, even a crush injury, even if it's not penetrating. Okay, so say for example someone gets rolled over by a bus or something. So something that is definitely crushing. Now the pathogenesis here with primary, and we talked about this a little bit, this also kind of goes with secondary as well. Primary pneumothorax, these people do also have blebs. Okay, so we talked about blebs with patients with emphysema. But these patients that do have a spontaneous one, they can also have bleb. We know that the bleb can collapse, or not collapse, burst, causing a lot of air in the pleural cavity, and there's your pneumothorax, okay? Secondary, same situation, but these patients have a pre-existing condition. So the pre-existing condition will cause extra air in the lung, giving them a bleb burst, and it puts all this air in the pleural cavity. Tension pneumothorax, what happens here is that there's a buildup of air or pressure in the cavity itself. So the air is there, but then say for example, if someone is, not to be so descriptive, but if a car runs over someone, okay, and they're under the car and they're just stuck there, that's actually increasing the pressure in the cavity, okay. So this is what we call a tension pneumothorax. Now, that's that. So, they can also have a situation where there's so much tension that they have what is called an open sucking chest wall wound, okay? So which means that the air enters during inspiration, but it cannot escape during expiration. So there, this causes obviously more of a buildup. Now, these individuals can have a shift in their mediastinum. And I'm going to show you a picture of it in the crazy looking picture. So this means, say for example, this person has a pneumothorax, whether it's spontaneous or crushing trauma, whatever it is. And say for example, they have in the right lung, okay, all this air just building up in that pleural cavity. What's going to happen is in the mediastinum, which you know what structures are there, in the mediastinum, because of that pressure, everything is just going to push and shift to that other side, to the contralateral side. So, and this can be seen on X-ray.
Is that painful?
I don't know, but I would imagine it causing some kind of pain or causing some sort of issue. One issue that it would cause, because the heart shifts with it. So one issue that you know it's going to cause is what? If the heart shifts, what's going to be an issue with the heart? Say that again. Well, cardiac output, which also, what goes along with that? They could have pulmonary edema, but before that, before it gets to pulmonary edema, it's just something very simple I'm looking for. Murmur, or let's say the cardiac cycle. The cardiac cycle is going to be off. So if the cardiac cycle is off, it will lead into having irregular heartbeats, yes, which will put the cardiac output, okay, not to be correct. If they have a decrease in cardiac output, yes, and the whole backup, this can cause a hypertension, yes, okay. So that can lead to a number of things. Okay, we're going to get to it. Okay, so clinical manifestations are here. You can just read this, study this. There's nothing to really say. Just reading it verbatim. Tachycardia, hyperresonance. And so hyperresonance, when you listen to the lung field and you listen to the sound and they breathe in and out, it'll sound louder. Why is it going to sound louder? Because they do have more air in that pleural cavity that is just causing that to happen. Okay. Dyspnea, yes, and somebody asked the question, yes, sudden chest pain on the affected side. Okay. So yes, this is painful. Tension and large spontaneous pneumothorax, this is more severe, where they will have severe tachycardia, but one thing that happens when this is severe, I would want you to highlight this, is that they do have a tracheal shift to the contralateral side. So the mediastinum, the trachea is also there, so everything just shifts and pushes over to the side. Another thing that I will highlight with this that's also like a hallmark with this disease is that these individuals do have subcutaneous emphysema. So what does that mean? These individuals, because they have all this extra air and it's sort of trapped, where do you think it's going to go? The next place it's going to move to is their subcutaneous tissue. So they will look bloated. It'll look like they have edema, but it's not edema. It's actually air under the skin, okay, in the subcutaneous space. So this is what that individual looks like. So it looks like fluid or look bloated, okay? What he looks like, somebody punched him in the eye, but what it is actually just air. So the air just kind of builds up under the skin in the tissue spaces. Okay. So diagnosis, ABGs, you already know what's going to happen, decreased O2. Let me correct this again. This will be respiratory acidosis, not alkalosis. And with the chest x-ray, one thing I want you to just really focus on with the chest x-ray is that, I don't know if you guys do any type of marking or lines if you look at chest x-rays, but in any event, just making sure that everything is uniform. So when you're looking at something like this, lungs should be in their proper place, mediastinum, whatever's in the mediastinum should be in its proper place. And so when you see things go outside of their boundaries, this is definitely saying that there's extra space or air in that region. So, let me turn this down because I really want you to turn the lights on. I really want to see this. So, this here is a patient that has a pneumothorax. So, which side is the pneumothorax?
Right.
Okay, here. All right. So all the extra air is here causing, you see this over here? This is, I think the top of this is the trachea. The bottom here is the heart. The heart is way over here. The heart's not supposed to be there. The heart's supposed to be in the middle, as you know. And the trachea should not be all the way over as well. Okay, the trachea should be also here in the middle. So this is a really good example of what they call that tracheal, or also known as mediastinal shift. They do call this a mediastinal. In the book, they call it a right to left shift. But just keep in mind, it all depends on what area there's more pressure. Okay, so then that tells where it's going to shift. But it will always shift, please understand, to the contralateral side. Okay, so not the same side. So, if we have the heart displaced, it would make sense for us to have definitely an arrhythmia, okay? Because the heart, as you can imagine, could not beat, okay, the way it should be normally if it's all the way over out of place. So they will have ECG findings. I'm not going to test you on the exact axis deviation and so forth because we didn't get into that, but just know that they will have ECG findings. Treatment. They say management depends on the severity, okay, so sometimes the lungs can collapse, okay, unfortunately, and so they will have to treat that accordingly. With that, they can give these patients oxygen if they need it, obviously, but then also they could do a chest tube placement with water seal and suction, okay, to kind of take care of that pneumothorax. Now, they can also do a couple of other things. Chemical pleurodesis. Okay, so what is that? They can actually give these patients a chemical that will actually decrease the amount of blebs, okay, that they're going to have. So it will take care of the blebs, or prevent the blebs, I should say, from rupturing. Then they can go in and take out the bleb surgically. Okay, so and that will also reduce it. Now, how is that done? I don't know. I haven't seen it done, but they can go and do that. Oh, that's it. I'm done. Yes, that's where I'm stopping. Now, just to let you know, what is pleural effusion? I think that's the last pleural disorder, but I didn't tell you to print that out. But just to let you know, this is when people go through certain disease processes, and in the pleural cavity, they may get blood, extra fluid, maybe exudative fluid. So that type of stuff can just pull up in the pleural space. So that's all that is, okay? And it all depends on what disease process they're going through. So I'm done with 23. Is everybody okay? Now, do we need a break, or can I go right into 36? Small break? Okay, let's take a small break. We have time, it's okay.